WHO Afro Media Briefing, which is taking place in collaboration with the APO group. Before we proceed, we will do some quick housekeeping first. Just go to the lower bottom of your screen. On the right-hand side, you will see the icon. So we have interpretation in English and French. Feel free to select whichever language you prefer. François, can you please interpret in French?
Bonjour et merci à tous d'être connectés pour ce point presse. Pour poser des questions, merci d'utiliser la fonction questions et réponses de Zoom qui est dans votre barre d'outils. Et pour l'interprétation en français, vous pouvez cliquer sur l'outil d'interprétation, le petit globe, et choisir français. Merci à tous.
Merci. Joining us from Brazzaville is Dr. Matshidiso Moeti, the WHO Regional Director for Africa. Please help me welcome Dr. Moeti, who will introduce the remaining panelists.
Okay, thank you very much, Mary, and greetings to all our colleague journalists. Bonjour à tous nos collègues journalistes, and also to everyone joining this press conference, particularly our colleagues from the APO group. We will be talking today mainly about the new COVID-19 variants circulating in Africa and their impact and potential impact on the situation, including the surge in new cases. I'm very pleased to be joined by Professor Tulio de Oliveira, who is the director of the CRISP at the National Mandela School of Medicine in South Africa, and by Dr. Amadou Sall, who is the director of the Institut Pasteur in Senegal. In the past week, more than 175,000 new COVID-19 cases and 6,200 deaths have been reported on the African continent, with countries, particularly in the northern and the southern part of Africa, accounting for the biggest increases. Cumulatively, there are now almost 3.5 million cases and 88,000 lives, unfortunately, have been lost. So in the past week, we've had more than 175,000 new cases on the continent. So WHO is tracking the emergence of different variants of the COVID-19 virus and updating guidance and strategies as new information becomes available. We are seeing more and more cases of variant N501Y.V2, which was first identified in South Africa, now cropping up in other countries. So far, 6 African countries and areas have confirmed cases of this variant, including Botswana, Ghana, Kenya, Mayotte, and Zambia. Beyond Africa, the variant has been confirmed in 24 countries globally, and there's concern it is circulating in other countries in Africa as yet undetected. So at WHO, we are working with countries to help them identify if this variant or others are circulating, to safely transport samples to referral laboratories for sequencing and analysis. The variant of concern first identified in the United Kingdom has also made its way to Africa with confirmed cases in the Gambia. The evidence suggests that these variants are more transmissible, and emerging evidence indicates that the UK variant may cause more severe illness than other common strains, although certainly more research needs to be done. Encouragingly, this week, at least 2 manufacturers have indicated that their vaccines are effective against both variants. In addition to the new variants, COVID-19 fatigue in the population and the aftermath of year-end gatherings and travel risk powering a perfect storm and driving up Africa's second wave and overwhelming health systems and facilities. It's important that all countries ramp up testing, isolation of contacts, and treatment of patients, as well as the preventive measures such as minimizing large gatherings. At WHO, we're working very hard with countries to prepare for the delivery of COVID-19 vaccines. And we encourage all countries to continue to do their best to be ready to roll out these vaccines to communities once they are available. We particularly encourage the government of the United Republic of Tanzania to prepare for the vaccine, to put in place the preventive measures to protect their population, and to share data on the COVID-19 situation with WHO and neighboring countries. Africa is at a crossroads, and all Africans must double down on the prevention measures that work so well: physical distancing, frequent hand hygiene, and the wearing of masks. I very much look forward to our conversation with two experts and also with members of our team in WHO who will be ready to jump in and also respond to any questions. Thank you very much.
Thank you, Dr. Moeti. Now we turn to Prof. Tulio from South Africa. Could you shed some light on the latest finding of the new variant of COVID-19, which was first detected in South Africa?
Okay, yeah, thank you, and good day to all our colleagues of the World Health Organization and colleagues across the world. Yeah, thank you for the invitation for this press release. Yeah, so in South Africa, as many of you will be aware, yeah, this variant, which the name is 501YV2 or the B1351, if one uses the other classification, the Pango, yeah, it has swept all through the country. Yeah, our last genomic surveillance from KwaZulu-Natal and from all around the country, it showed that variant at very high prevalence. Yeah, normally more than 90% of the genomes that we produce, it is this variant. So it seemed that not only has spread very fast in the country, but in many different provinces, dominating most of the infections. Yeah. So South Africa decided to act very quick and with transparency against this variant, yeah, with both increasing the response, yeah, and that also increased some of the restrictions within the country, and we have the signs that has been quite effective. So far, we see a very big decrease on number of cases and hospitalizations. However, our excess deaths, it is now almost double as it was on the first wave. Yeah. In relationship to the spread of this variant to other countries, yeah, we at the moment, as highlighted in the study, it is spreading quite widely around the world. Yeah, it's depending how you count. We count them two ways: counts that reported the variants and countries that sequence from the variant available. Yeah, and if one look for the different ways to report, yeah, so 29 countries have reported the variant, but there is sequence available for 22 different countries around the world. Yeah. And in the African subcontinent, in the African continent, yeah, new countries have been reported the presence of this variant. Yeah, with yesterday the Minister of Health of Mozambique reporting that the variant was also have entered Mozambique. Yeah, and Mozambique also had a fast increase of cases since December. Yeah. We are currently working with a very big group of a network in South Africa to understand not only the spread of the lineage, but the implications of the biological implications. And in the last 2 weeks, yeah, we released some very important results in relationship to the neutralization of this variant by convalescent plasma of patients that were infected in the first wave. Yeah. And the results were consistent both between our group and the African Health African Health Research Institute on live virus that showed that this variant is less neutralized, much less neutralized than the previous variant, but also by the team of the National Institute of Communicable Disease, led by Penny Moore, that did that on pseudovirus, showing also much lower neutralization by convalescent plasma, these antibodies from the previous infections. Yeah. One piece of good news, it came that the vaccines, they normally elute much higher level of antibodies than primary infections. Yeah, so we are still confident that the vaccines will be effective, because in addition of the higher levels of antibodies, you also have the other part of the immune system, this T-cell response. And Moderna was the first one to release some results showing a slightly decrease on the neutralization from antibodies, but the vaccine is still effective. Of course, the Moderna vaccine is not the most appropriate for the African continent due to the very low cold chain that need of -80, but that despite that's quite good news to see that. Yeah. At the moment in South Africa, we are trying to work to answer another few very important questions. The one is this variant cause more reinfection than previous variants, and the other one, it is using the same pseudovirus and live virus experiment to see the neutralization with people that have been vaccinated, yeah, as part of trials in the African continent. Yeah. Just to finalize, we also have set up a very important partnership with the Africa CDC and the World Health Organization through the Pathogen Genomic Initiative in the African continent, and we have selected half of our genomic throughput. Yeah, so we will be able to offer all the African countries up to like 200 or 300 genomes a week, so we can help them to also characterize the variants that are circulating. More important, we're going to do that in a holistic approach that, in addition of generate data from them, that's going to have a strong capacity building program, because our vision is that the countries can do this genomic surveillance themselves as the time advances. Yeah, thank you for.
Thank you very much, Prof. Now we'll go to Dr. Amadou Sarr. Can you please tell us about how the Pasteur Institute is supporting countries to dictate new variants?
Thank you very much. Grand merci justement à Mary Stephen. Et je voudrais d'abord dire le plaisir que j'ai de partager ce plateau avec la directrice régionale de l'OMS, le Dr Moiti, et le professeur Tulio Oliveira, qui sont vraiment des personnes extrêmement engagées et mobilisées dans cette lutte contre la COVID, et particulièrement dans le sujet qui nous intéresse aujourd'hui. Alors, par rapport à l'Institut Pasteur de Dakar, je voudrais d'abord dire que dans le dispositif sénégalais, l'Institut Pasteur de Dakar a en charge la surveillance génomique, qui a commencé dès le 5 mars, au début donc, de l'épidémie, et c'est quelque chose qui se poursuit pour non seulement séquencer des souches du Sénégal, mais depuis le début de cette période, on a une capacité et on a aidé plusieurs pays dans ce sens-là, que ce soit le Cameroun dans un premier temps, la Guinée équatoriale, en plus du Sénégal. Au niveau du Sénégal, donc, ce séquençage, cette surveillance génomique a lieu quotidiennement, et à ce stade, on a plus de 700 souches qui ont été analysées dans le but justement de voir les évolutions qui pouvaient toucher le diagnostic, les vaccins ou les traitements s'il y avait du nouveau. Ce que je peux dire avec toute cette partie, il y a quand même une attention particulière qui a été portée au cours de ces 2 derniers mois, enfin même 3 on peut dire, depuis le mois de novembre, à une analyse beaucoup plus systématique de plus de 200 souches, avec l'objectif de voir très clairement est-ce qu'il y avait ce nouveau variant. Aujourd'hui, je peux dire au Sénégal, après un séquençage de plus de 200 souches qui ont été choisies pour couvrir l'ensemble du pays, à différentes périodes, nous n'avons pas identifié des variants du coronavirus 19. Ça, c'est le premier point. Le deuxième élément que je voudrais dire par rapport à la sous-région ouest-africaine, nous avons aujourd'hui vu que la Gambie a rapporté déjà 3 cas de variants, tous venant d'Angleterre, et au niveau du Nigeria, des variants ont été rapportés, que ce soit d'Afrique du Sud ou d'Angleterre. Maintenant, par rapport aux capacités de l'Institut Pasteur, il y a à ce jour-là, dans le cadre du programme Genomic, l'initiative de séquençage mis en place par l'OMS et mis en place aussi par l'Africa CDC, il y a une organisation pour aider plusieurs pays qui nous ont été désignés pour la région. Je vais les nommer rapidement, c'est le Mali, le Burkina, la Guinée-Bissau, la Côte d'Ivoire, le Niger et le Cap-Vert, et bien évidemment la Guinée. Il y a la Gambie qui a des capacités en interne. Ça, c'est par rapport aux pays que l'on va couvrir dans le cadre de cette région. Mais il y a des initiatives aussi qui sont faites au niveau des instituts Pasteur, où aujourd'hui 9 des 10 instituts Pasteur qui existent sur le continent africain vont envoyer des séquences au niveau du Sénégal pour renforcer justement ces capacités et faire du séquençage le temps que ces pays soient prêts. Il s'agit de l'Algérie, de la Tunisie, du Niger, Côte d'Ivoire, du Madagascar, du Cameroun, de la Guinée et des différents pays qui sont hébergés par les instituts Pasteur, ce qui permet aussi d'avoir cette capacité qui est déjà disponible. Et nous sommes en train de travailler avec la Banque islamique de développement pour appuyer ces autres pays. En termes de capacité, aujourd'hui, avec ce qu'on a bâti avec l'OMS Africa CDC, nous sommes en capacité pour traiter jusqu'à 500 génomes par semaine. Et cette capacité, on est en train de s'organiser pour l'augmenter, pour mettre à disposition le temps que ces différentes capacités puissent être disponibles dans les différents pays. Alors, l'autre élément qui me paraît important au-delà du séquençage, et le docteur Moeti l'a rappelé, c'est qu'il faut qu'on ait une capacité à échanger des données. De ce point de vue-là, l'Institut Pasteur de Dakar est un hub de la plateforme mondiale GISAID, qui jusqu'à présent a en fait la capacité donc de les faire à partir de cette plateforme, de faire l'échange rapidement aussi longtemps que les pays le souhaitent et sont disponibles. Ça aussi, c'est un deuxième élément parce qu'il s'agit d'apporter une assistance sur le séquençage en tant que tel, mais sur l'analyse et mettre ces informations disponibles pour que les différents pays puissent l'utiliser. Plus concrètement, dans l'immédiat, donc la semaine dernière, nous avons traité pour la Mauritanie un peu plus de 20 génomes et actuellement, on s'apprête à en recevoir du Cameroun, de Madagascar, en plus de ce qu'on fait du Sénégal. Et cette capacité, on va la monter dans les prochaines semaines et avec un minimum dans les 2 prochains mois de faire 1500 génomes, mais des possibilités d'en faire un peu plus. Voilà ce que je voulais dire concernant les capacités au niveau de l'Institut Pasteur de Dakar et la disponibilité pour aider dans le traitement des séquences ou aussi pour aider dans le séquençage de ces génomes. Merci.
Thank you, Dr. Sarr. So now that we have heard from all the panelists, it is now time to ask your question. Please use the Q&A function on the Zoom to ask your question. Tell us your name and the name of the news media you represent. Also to remind you that we have translation in French and English. You can use the globe icon and select your most preferred language. Let's go now to David from Financial Times.
Hello, yeah. Hi,
yes,
I hope you can hear me.
Yes.
I have a lot of questions, but I'll limit myself to 2 initially. First of all, I would like to know what an appropriate vaccine strategy in the African continent, insofar as one can talk about the African continent as a whole, what that would look like this year in terms of, the rollout of the vaccine, what percentage of the population could realistically be expected to be vaccinated by the end of this year, and the mixture of vaccines, you know, whether the AstraZeneca or the J&J that is not yet proven, or even the Chinese and Russian vaccines. So I'd be interested in an overview of the vaccine strategy. A different question. There was a report of a non-peer-reviewed paper out of Boston University that was that looked at people who had died in Zambia. So and it tested people for COVID in the morgue in Lusaka, and found that there was a much higher prevalence of COVID than had been reported. Now, this is unpeer reviewed and was only taken in one city, but the implication from the researchers of this report was that perhaps COVID cases were being undercounted in parts of the continent. I'd be very interested in your opinions of whether you think that is a plausible hypothesis or not. Thank you.
Thank you, David. I will pass your question to Dr. Moeti, and then Dr. Richard could complement. Over to you, Dr. Moeti.
Yes, thank you very much from our colleague from the Financial Times for those two questions. I think I'll ask Richard to start with a question on the vaccine strategy for the continent, and then I will say something about the possible underreporting of cases in Africa. So Richard, do you want to come in?
Yeah, thank you. Thank you, Dr. Moeti. And good morning to the colleague from The Economist. I think this is a very important question. With regard to the vaccine strategy in the region, I think our strategy has been consistent with what WHO has been advising the country in light of the very limited vaccine doses that are currently available. And this is not specific to Africa, by the way. I think we are seeing it even elsewhere, even in the high-income countries. The strategy has been really first to prioritize the most vulnerable groups, starting with the healthcare workers, and then moving to other people who are living with comorbidities or being defined by the countries as a special group of interests. So in terms of the percentage that could be realistically be reached before the end of the year, I think there are two major avenues that we are pursuing here in Africa. The first one, indeed, is the initiative that is mainly led by WHO, Gavi, the Vaccine Alliance, and CEPI through the COVAX. And the objective is to reach 20% at least, to cover 20% of the population by the end of the year. And I might say that with the latest development within the COVAX facility, there is a very, very good prospect that this objective to supply up to 600 million doses by the end of 2021 will definitely be reached. The other interesting avenue that we are looking at, it's the African Vaccine Acquisition Task Team, which is an initiative led by the African Union Commission that is planning to complement or augment the capacity of the vaccination that is going to be supplied by COVAX. So there was an announcement last week of close to 270 million doses that has been secured through that initiative. But we know very well that some of these doses may not become available soon. So realistically, we could expect around another 10, 15, or 20%, 10 to 15% that could be covered. So globally, reaching 30, 35% could be a realistic assumption by the end of 2021. So in line of the different vaccines, as we know, all the countries, even beyond Africa, are looking at the different products because we can't have only one vaccine to cover the needs. The deals that has been secured through COVAX mainly the AstraZeneca vaccine. But also last week, there was an announcement of 40 million of the Pfizer vaccine. With the African Union as well, there is an agreement with Pfizer vaccine produced by Serum Institute of India, as well as a few doses with the Pfizer vaccine. But I would like to conclude by saying that WHO is continuing to explore the emergency use listing of additional candidate vaccine. Currently, the Sinopharm vaccine under evaluation by WHO, and we are expecting maybe before the end of the year to have some good data with the Johnson & Johnson vaccine, which will use one dose, and that will be very interesting for many reasons in terms of the logistics for the African region. So I will stop here, Dr. Moeti, and thank you.
Okay, thanks very much, Richard, for that comprehensive answer. I mean, as far as the undercounting or underestimation of cases in the country, so we have no doubt that because of the challenges that countries have faced since the beginning of the pandemic, and the situation has ebbed and flowed with access to testing supplies, especially, that the rates of testing have varied a great deal in the region, but we have had over 20 countries consistently testing at lower rates than WHO would be recommending, which is 10 per 1,000 population. So what we've seen is that generally the smaller and middle income countries have been able to acquire these supplies and are testing at above the minimum recommended rate of WHO. And it's tended to be the low income countries that have really struggled. We are very much reliant on international aid, on donations, and have been part of the confrontation really with the distorted global markets in these supplies, especially where testing has been suboptimal. So it is quite likely, and we've said so repeatedly throughout last year, that there's no doubt that the number of cases that are reported underrepresents the number of people that are infected. And it's a very good thing that now we have rapid tests that can test for antibodies, for example, that then will be able to tell us to the degree to which the virus is likely to have been circulating in any locality and enable then the adjustment of the strategies accordingly.
Thank you, Dr. Moeti. Nabila from ETV News, please ask your question.
Hi, this is a question to be directed to Professor Tulio. He made an announcement last week about a new variant that had been found in KwaZulu-Natal called the B1.1777. What do we know about this variant so far? Because we haven't heard anything officially about it. And my second question to him is, currently, as a country and where we're going, is there a potential of us seeing a third and a fourth wave in South Africa?
Okay, thank you. Yeah, so a number of things. Yeah, South Africa has implemented quite a detailed genomic surveillance network. Yeah, and to be honest, we have seen hundreds of lineages, yeah, in the country, which mostly got replaced by the 501 V2 or the B1351. Yeah. One thing that as we continue our genomic surveillance, we see some lineages that are continuously being introduced in South Africa. I wouldn't call them a variant, because a variant is what we are reserving at the moment as we call a variant of concern. Yeah, so we have detected a B1.177. This is a very common lineage that has circulated in Europe in the autumn, yeah, and also in the winter. Yeah, it's not the B1.17, but today we just reported the first important case of the B1.17. That is the variant of concern that is in the UK. Yeah, and it's quite common that in addition to the variant that's dominating, we're gonna still have like introductions of new lineages, yeah. And in the case they become to spread very fast, yeah, then we will communicate it as probably and then highlight that could be a variant of concern. But for the moment, these two introductions, yeah, most probably from the UK, that's where these variants they had high prevalence. Yeah, they seem to be single introductions that have been South Africa, and they don't seem of being spreading very fast. Yeah. In relationship of your next question, if you can expect the third or fourth wave, yeah, my honestly answer is that we don't know. Yeah. And I think that one of the things that this variant highlighted to the whole world, yeah, is that this should be a really wake-up call to control transmission of SARS-CoV-2, not only in their own country, but to try to control transmission as a global community, yeah, because we have to really decrease transmission to avoid the next waves, and more worried the emergence of new variants of concern that could transmit faster or evade immune pressure.
Okay, thank you, Prof. The next question is going to Dr. Moeti and then Dr. Sao. Dr. Moeti, your question, what do you think of the decision by ECOWAS to standardize the cost of PCR tests? Is there a WHO initiative to make the test more available and or affordable on the continent? And then the second question goes to Dr. Sal. Is it known how many people are tested per day in Senegal, apart from travelers and people with symptoms? Do you believe that improving testing capacity could help stem the second wave in the country? So Dr. Sal, you can answer in French, but first, Dr. Moeti, over to you.
Okay, thank you. Thanks for that question. I think it's a very good idea, initiative by the ECOWAS leadership, political leadership, to decide to standardize the cost of PCR tests. And I believe the motivation was to make this testing affordable for people so that to maximize knowledge of people's status, particularly in relation to cross-border travel, so that there's some sort of standardization. Somebody's traveling from one country to the other, and to encourage and enable people to be tested, and all sorts of people. So people who must travel, people who have resources, and people who might be engaged in business, family travel, who have limited resources. So this, I think, was just to push affordability and enable then the implementation of the regional protocol on managing and controlling transmission in across the borders. Is there WHO initiative to make tests more available? I think we've worked very hard as WHO since the very beginning of the pandemic at all levels, starting with a global platform that WHO put in place with partners such as UNICEF and others to pool the procurement of tests so that we could compete on a very difficult global market and procure supplies, particularly for low-income countries and for countries that need support, including up and some extremely, and as I said earlier, our countries have struggled, our countries have struggled throughout to make tests available. Certainly what we do to make tests affordable also is to disseminate information on the pricing of tests, so that enables those who are procuring to be able to negotiate provided. We think WHO has been doing for many years in terms of improving access to affordable items, medicines, I needed for diagnostics, for the pandemic.
Okay, thank you, Dr. Moeti. Dr. Sal?
Yes, thank you. Concerning the question about Senegal in terms of capacities, just wanted to mention between the beginning up to now, Senegal has actually multiplied more than 10 this capacity in terms of decentralizing. We start with 2 labs in Dakar, and now it's in all different countries. We have more than 14 labs for a country, covering quite well the whole country in terms of the capacities. Senegal have no specific capacities based on the strategy that has been defined. Every day we test between 1,600 to 2,000 tests, which is really trying to focus on reducing the transmission and focusing on symptomatic case and running the contact around. Now, concerning that, the fact that we're testing with travelers and we're testing at the same time with for the surveillance, this is the national strategies, but I don't think there is any problem with capacity and to test more. Recently, the government has also decided to deploy much larger leveled the rapid test, the RDTs, and to make sure that we are capturing all the different people that are tested. This is also done with a digital platform, which is being put together in place. So far, that's the strategy. We're gonna amplify the number of one, but all we wanna do is do that in a controlled manner that people can not only test for testing, but complementing the strategy into isolating and making sure we treat people that are positive. So this has to be seen as an integrated system. That's why it is done very careful. Over to you.
Okay, thank you, Dr. Sal. The next question is from Lisa from VOA. Lisa, are you there?
Yes, I am. Thank you.
Please go ahead with your question.
Thank you very much. To Dr. Moeti or any of the other panelists who wish to jump in. Dr. Moeti, you mentioned COVID fatigue among the African population. I believe the whole world is fatigued. Are you afraid that this could result in a huge spike of infections throughout the continent? And given the reported increased contagion of the new variants, are you fearful of having your hospitals being overwhelmed by patients? How will you be able to handle this? And then one other quick question, please, and that is, Dr. Tedros recently mentioned that only Guinea had received 25 vaccines, and that I'm wondering whether the COVAX facility is operating better and whether Africa has now received vaccines. If so, how many? Are you anticipating more? And how will you ensure the fair distribution of these vaccines among the dozens of African countries? Thank you very much.
Okay, thank you very much for those questions, Lisa. With regard to the fatigue and its potential to drive up and produce subsequent waves, of course, we are very concerned about this. And we are emphasizing in our work with the governments, the countries, with our partners such as UNICEF in the UN and others who are playing a strong role in communication, that it's very important to re-energize and help people to sustain these ways of being, these ways of living on a day-to-day basis, of which they've become a bit fatigued. I mean, if you look in all the places that I've been recently, here where I'm living, I was in Southern Africa recently, there is no doubt that you are seeing more and more people walking around. The mask is not quite properly covering the nose and mouth. Increasingly, I'm seeing people without a mask at all, and this is becoming natural. And the physical distancing is becoming a bit tiresome. These interventions must absolutely be re-stimulated in people. I believe that, and we are working with our team here in Afro and our partners to, in a sense, restart and reboot the communication, add to what has been happening already, and link up with communication groups, networks of people, trusted sources of information, and send the message again that people understand not only is it protecting you, it is very much protecting your families if you do this consistently when you're out and then you come back home. And it's what's going to help us all normalize life and go back to jobs, economies, schools reopening. It's very important to reinforce, strengthen, sustain the communication. It's very important as well to know what people are thinking and feeling. What is it that is adding to the fatigue, and what can help people find this more relevant to do in their own lives? So it's very much a concern, and it's something that we are working with governments to continue to reinforce, in addition, of course, to strengthening those public health interventions like testing, contact tracing, and isolation, which are all part of the package to contain the risk of further waves of the infection. I'll ask Richard again to talk about the vaccines, the COVAX, just to say that at a moment when the whole world is anxious to get going with this vaccine, we start seeing some countries with more resources to have acquired supplies earlier start vaccinating. I think we can note with concern and disappointment that it wasn't possible to start everywhere in the world at the same time, but we very much need to take the time then to ramp up the preparedness, the readiness, so that when the vaccines arrive on the continent, the type of campaigns that are carried out to deliver them are absolutely effective, are very efficient, and that we make sure that we cover all the people that need to be covered as soon as possible with these very effective, well-prepared delivery campaigns. So Richard, if you could perhaps provide more information about when vaccines are expected to be arriving on the continent.
Yes, thank you, Dr. Moeti. So with regards to the start of the vaccination in a few countries, the journalists referred to the few doses that has been administered in Guinea. But just to inform our audience that few countries have started vaccination. Seychelles started since now 3 weeks now to immunize the population. And they've immunized so far close to 25,000 people. And the vaccination, the campaign is still going on in Seychelles. They are using the Sinopharm vaccine. Mauritius started vaccination since 2 days ago using the AstraZeneca vaccine. And the data that we have received this morning is showing that close to 450 people have already been immunized. Morocco received 1.5 million doses last week and is going to start vaccination tomorrow, by the way, if not today. As well as other many countries have started to, South Africa has ordered close to 1.5 million and is expecting to start vaccination quite soon. But overall, as explained by Dr. Moeti, I think we all agree that the current situation of supply chain have not facilitated things on the region. But with the latest announcement that was made through the COVAX facility, we are really hoping that the first dose is going to be started to roll out in Africa, probably by mid next month. And by March, we will definitely see most of the countries starting vaccinating with targeting the high-risk group. And I think in terms of the fair distribution of the vaccine, this has been one of the guiding principles of the COVAX facility right at the beginning, to make sure that all countries can access some part of the people can get vaccination in all countries at the same time. Really, that is the core part of the initiative that is launched through COVAX. And we believe that with this prioritization of people who are most at risk, who are healthcare frontline workers, I think it will achieve a minimum of equity to make sure that those who are needed vaccine can get it first. And while the dose become available, the supply could be ramped up and the vaccination continue. So it is a slow start, but we are expecting that in the coming month, things are going to ramp up. And as said, Dr. Moeti, we are using this window of opportunity to strengthen country readiness and preparedness to make sure that whenever the vaccine arrives, all the country will be 100% ready to start rolling out these products. Thank you.
Thank you, Dr. Richard. Just to remind journalists that please, you should limit your question to just only one question. The next question is to you, Prof. This question is coming from Tama Khan from Business Day. How do you think the race between vaccine developers and the mutating coronavirus is going to play out? Are we heading for a situation where we need an annual coronavirus shot? Over to you, Prof. Tulio.
Yeah, thank you. Yeah, so that's a very important question. Yeah, and that's where we find that setting up genomic surveillance to quickly identify variants, but also programs, basic science programs to also see how these variants behave in the lab to the new vaccines, followed by good trials in Africa is very important. Yeah, of course that our dream for the COVID-19 vaccine would be something like the measles or the polio vaccine that you take once and you're protected for life. Yeah. At the moment, we have very strong reasons to believe that the current vaccines is still going to be efficacious against the variants that exist. Yeah. And for example, one of the vaccine manufacturers is also already start developing what they call a booster for some of the new variants in case that is needed. Yeah. So I think that time will tell if we're going to have a fixed vaccine or a vaccine that need to be updated and more than ever to both decrease transmission, but understand very well what is circulating, its crucial importance.
Thank you, Prof. George from Reuters, if you're online, please ask your question.
Okay, yes, I am.
Go ahead.
It's to the WHO regional director. Just following up with what you said about Tanzania, what is WHO doing beyond just calling and urging Tanzania to prepare for vaccination and do more to spread this, to prevent the spread of COVID-19 and share its data? Also, what concerns do you have that the stance that WHO has taken today against Tanzania will not lead to your representative there being victimized, as it happened in Burundi last year?
Okay. I mean, first of all, what is WHO doing? You know, we have been communicating with the Tanzanian government throughout this pandemic at the three levels, certainly at the level of our country representative and her team, consistently with the Minister of Health and also with the Minister of Foreign Affairs at a certain point in time. I have communicated myself with the Minister of Health. The Director General of WHO has communicated with the Minister of Health, of Foreign Affairs, and we have made attempts to also communicate at the highest level of the leadership of the country. We've also provided the country with support in terms of the preparedness for dealing with the pandemic, as we have with every country in the world and the region throughout the pandemic. We have restarted this communication now, as I've said. So we have been and our country office has also provided support for the country to do what was needed in terms of preparing to respond for the pandemic. We are now, as indicated, particularly wishing to have the country take the opportunity, like all other countries, of the tool that is the vaccine that's available. And therefore, we are re-initiating our communication at the highest level of leadership and offering our support as we have done throughout the situation, and looking for collaboration with Tanzania for the sake of the people of the country, for the sake of the people of the neighboring countries, and as well for the sake of the world. What part of our communication has been to remind the government that it is a signatory of the international health regulations in which states parties or member states have accepted to work collectively to prevent the international spread of disease. One of the actions there is to share information about any cases that are occurring of any epidemic-prone disease. And we have I have in writing, reminded the government of their being part of this global club and therefore of their obligation to respond in this way. It is our hope that our communications, especially the reinstated communications about the vaccine possibility to then, more definitively ensure that the virus is not circulating in the countries, will find a positive response. We are expecting the country to be like a member state of the United Nations in terms of their collaboration with our local team, in addition to our collaboration with us at the regional and the global level. And we hope to have a dialogue which will have positive results for the actions to prevent the further spread of the COVID-19 vaccine in the country, in the region, and also in the world through the participation of all member states in this collective action.
Okay, thank you, Dr. Moeti. The next question is from Lova from Madagascar Radio. Lova, are you online? Okay, if she's not there, I will just read out her questions. And this question will be answered by Dr. Sarr. Feel free to answer in French, please. Do all African countries have the means to know which variant is circulating in their territory? Dr. Sarr, please.
Oui, actuellement, donc, par rapport aux capacités des pays africains de savoir les variants qui circulent chez eux, je pense que plusieurs pays ont des capacités pour faire du séquençage, qui est la méthode dont on a besoin pour le savoir. Et donc, de ce point de vue-là, si la capacité technique existe, il faudrait juste un système de surveillance qui soit suffisamment élaboré pour capturer les différentes souches qui circulent de manière à ce que les séquences puissent être faites régulièrement. Au-delà des pays qui en ont les capacités propres, l'OMS, Africa CDC et tout le dispositif au niveau régional, l'OAS, sont mis ensemble pour s'assurer que les pays qui n'ont pas ces capacités-là peuvent être soutenus par des centres régionaux comme l'Institut Pasteur de Dakar et des autres qui ont été désignés dans le cadre du réseau qui a été mis en place pour cela. Donc aujourd'hui, potentiellement, tous les pays ont la capacité de le faire ou en local ou à travers le réseau mis en place pour avoir cette information. Et cela dépend aussi de la capacité du pays à faire de la surveillance pour couvrir les points d'entrée, pour couvrir aussi à l'intérieur du pays, de manière à avoir un maximum de souches à séquencer pour voir justement cette information. Merci.
Thank you, Dr. Sarr. The next question is from Jean at RFI. Last week, the president of South Africa complained that African countries have to pay 2.5 times more than the developed countries for vaccines. How can this be explained? Dr. Richard, please.
Well, so it's something that we all have difficult to understand. Indeed, it's a shocking fact that a rich country can pay less than those countries that are struggling. However, when we looked at the market dynamics, particularly in this situation where the products are very scarce on the markets, and the rich country claiming that they've pre-financed the development of this product, therefore getting a preferential price, it's difficult as well to translate that is a no day-to-day understanding on the market dynamic. However, and I think that has been highlighted, and the position of WHO and our leaders Dr. Moiti, Dr. Tedros have called really since the beginning of this on this issue of global solidarity and equitable distribution of the vaccine. This should not stay at the level of distribution, but should be also for those countries that are self-financing. They should access the vaccine at a fair price without, of course, jeopardizing their own economies. I think we need to stress that we still do have countries in Africa that are not eligible to this donation scheme, that have to purchase the vaccine themselves. This is the case of South Africa, but we have also other middle-income countries in Africa, Namibia, Botswana, Mauritius, Seychelles, Gabon, Equatorial Guinea, that are in a situation where they have to pay themselves. So I think it's time really to call for a fair price for those countries so that they can access vaccine at a minimum to the same level of the price that rich countries are getting.
Thank you, Dr. Richard. Then we have a question from Mathilde. She's from Le Monde in Joburg. Their question is going to Prof. Tulio. What are the sequencing capabilities on the continent? Apart from the Institute Pasteur in Dakar and CRIPS in South Africa, what are the main research centers taking part in genomic surveillance? Is the current cooperation something new in the scientific world throughout Africa? Prof, please.
Okay, yeah, thank you for the question. So at the moment, we have many sequencing centers in the African continent. Of course, not as many as we would like, but very important. We have started almost a year ago a comprehensive program, which is called the Pathogen Genomic Initiative. That's a collaboration between it's coordinated by the Africa CDC, together with the World Health Organization. Yeah, in this program, it's involved 52 countries. Yeah, and you have 3 different levels of laboratories. Yeah, you have what we call a specialized lab that has a lot of sequencing capacity, and at the moment we have 2. One in South Africa that I direct, that's called CRISP, and another one in Nigeria, that's Professor Christian Happier, and that's a laboratory that have more capacity, and they are sparing capacity to support the other labs. Yeah, and then you have regional labs. Yeah, that you have many more regions that also do genomic capacity for the region and the country, and then national labs. Yeah, so at the moment it is many more labs are being equipped and getting ready for the genomic surveillance. Our expectation with the Africa CDC and the WHO is this year to ramp genomic surveillance to at least 30,000 genomes in the African continent. Yeah. But what we are looking is not just for numbers. What we are looking is a very pragmatic and systematic approach that we sequence, like, for example, like 100 or 200 genomes for a given country every month. And that is continuously together with the national laboratories, which would be responsible for selecting appropriate representative sampling.
Okay, thank you very much, Prof. We have another question from Mark Santora from the New York Times. Can you please expand on what we know about the effectiveness of the AstraZeneca vaccines, specifically as it relates to the variant identified in South Africa? Also, is there any data on Russian or Chinese vaccine and the variants? Prof, you can start and Dr. Richard can complement.
Okay, thank you. Yeah. At the moment, I personally don't have any data on the AstraZeneca vaccine and the effective on the of the variants, but we know about many colleagues in South Africa that has run the vaccine trials. Yeah, that are currently analyzing this data as the vaccine trials it finish, and so I believe that that should be public data in the next few days or in the maximum a week, but I don't have that kind of information at the moment.
Okay, Dr. Richard, please.
I'm sorry, Mary, I didn't very well, the line was not good. Can you please repeat?
Okay, the question is from Mark from New York Times. He's asking, can you please expand on what we know about the effectiveness of the AstraZeneca vaccine, specifically as it relates to the variant identified in South Africa? Yes.
Yeah, well,
and also if there is any data on the Russian or Chinese vaccines and the variants.
Well, as my predecessor said, there is very limited information yet on these other candidates, these other vaccine on their efficacy on the new variants. I think probably this is still been too early to say. So for the moment, we just don't have enough data on that, apart from what was published by Moderna and Pfizer, which are both vaccine that are using the messenger RNA platform. So we will have to wait a bit to see what will happen with the other vaccine using a different platform.
Okay, thank you, Dr. Richard. The next question is to you, Dr. Sal. There is a recent announcement from Professor Mbu that the British variant is now in Senegal. So what can you tell us about this new variant and how it explains the speed of infection in Senegal?
Vous avez raison, je viens d'entendre l'information. Au moment où nous faisions cette conférence de presse, j'ai entendu, on m'a passé l'information qu'un autre centre qui travaille au Sénégal, dirigé par le professeur Mouk, avait identifié dans des prélèvements le variant anglais. Mais je n'ai pas plus d'informations que cela. Au moment où on démarrait cette conférence avec les informations, on n'avait pas aucune nouvelle justement de la présence du variant anglais sur le Sénégal. Maintenant, riche de cette expérience, je vois 2 ou 3 points qui me paraissent importants de continuer. C'est de continuer la surveillance génomique au Sénégal pour savoir ce variant-là, son ampleur dans la circulation. Est-ce que c'est le cas, comme on a pu le voir en Afrique du Sud, qui a remplacé les différents autres variants? Mais aussi de continuer à travers cette surveillance, de voir par une analyse épidémiologique détaillée si la circulation de ce variant a un impact sur la virulence ou sur la capacité d'être neutralisé. À ce stade, c'est tout ce que je peux dire. Je vous remercie.
Thank you, Dr. Sal. The next question is to you, Dr. Moeti. This question is from Eniola from Punch, Nigeria. The Nigerian government says they are prioritizing health workers, the vulnerable, and government officials for vaccines. Wouldn't priority be given to government officials undermine equitable distribution of vaccines?
Thank you very much. I think WHO has provided guidance on prioritizing and how to sequentially distribute the vaccine and vaccinate different population subgroups with a combination of, one, their role, their very important role as far as health workers are concerned in the response to the pandemic and the potential spread in the healthcare settings of this virus. And then secondly, of course, to do something about mortality. I imagine, I have not seen in detail whether government officials means every single government official in Nigeria. I imagine there would be a breakdown of people playing critical roles in certain areas of the economy, development, health, perhaps such areas as education. I think one would need to understand better what this means. What we would like to emphasize is the principle of, first, the idea is to, as quickly as possible, get a maximum number of people who play certain roles in countries, in the health system, in other parts, critical parts of the economy, protected. One, to break the chain of transmission, and two, to have an impact on the level of mortality by protecting those who are most vulnerable to getting serious parts of the infection, and then progressively rolling out to the rest of the population. This is what I can say.
Thank you, Dr. Moeti. The next question is to you, Dr. Richard. Which vaccine candidates are likely to be the most useful from African countries? This question is coming from a new scientist.
Well, I think we have heard this question several times. I think for the moment, I believe that the priority really is to use the available vaccines that could be out there to make sure that people are protected. But having said that, we know that some of these vaccines come with different features that are making them quite very difficult to be rolled out in certain places because of the characteristics of the product themselves. So in that regard, as you know, WHO, we don't recommend specific product. We recommend vaccines that could be easily be used and rolled out in the different community. So it's true that vaccines that are going to use the regular cold chain system will be of great favor for many countries. Also, vaccine that will use for example, 1 dose versus 2 doses are really going to be quite very attractive for many countries. So we do have few products for the moment that fits that characteristics. I think the AstraZeneca one is cheap, is being stored in a regular temperature. The upcoming Johnson & Johnson vaccine will also be very attractive to the fact that it only be using 1 dose and be stored in the regular cold chain system. But the priority now is really to immunize people as soon as possible with the available vaccine. But as we roll out the product, all of these parameters are going to play to make sure that the vaccination become sustainable.
Thank you, Dr. Richard. We are coming to the end of this press briefing for today. So let's turn back to our panelists for their final words. So we will start with Dr. Sal, Prof. Tulio, then Dr. Moeti.
Oui, pour ma part, je voudrais d'abord remercier pour cette conférence et toutes les questions très intéressantes et dire que dans le domaine qui aujourd'hui nous a un peu occupés, à savoir les vaccins et les variants, je voudrais dire que par rapport aux capacités actuelles de séquençage, il y a vraiment une dynamique qui s'est installée qui permet déjà d'avoir un appui entre les différents pays pour justement connaître et mesurer exactement la circulation et qui progressivement, comme on l'a fait pour le diagnostic et pour les autres contre-mesures médicales, va s'installer sur toute l'Afrique selon les dispositions qui ont été mises en place. Le deuxième élément, c'est que ce variant-là, les variants font l'objet d'une étude extrêmement active sur laquelle l'Afrique, nos pays sont dans une dynamique extrêmement claire pour pouvoir avoir un maximum d'informations et adapter notre stratégie par rapport à l'évolution de la circulation et de la connaissance qu'on a de ces variants. Et dernier point, dans ce contexte-là qui me paraît important, toute notre réflexion sur le vaccin, comme l'a dit le docteur Moeti, se fait dans un cadre de préparation. Et même si les vaccins arrivent un peu plus tardivement que dans les autres continents, il faut mettre à profit cette période-là pour justement étudier toutes ces questions et se préparer au mieux à leur déploiement. Voilà, et c'est les points sur lesquels je voulais insister et vous remercie en disant à l'Institut Pasteur de Dakar, bien évidemment, pour cette période-là, une mobilisation pour appuyer au Sénégal, dans la sous-région ouest africaine et au-delà. Merci.
Thank you, Dr. Sal. Prof?
Yes, just to thank the WHO for this opportunity. And my last remarks is just to say that the appearance of these variants, both in the African continent, but in South America and the Europe continent, it really means that more than ever is the time that we don't leave any continent behind, especially on the vaccination, but also on the main public health response. So more than ever, it is a global responsibility to increase and support both, especially Africa, to also scale vaccine in the same way as the developed country. We really have to protect our healthcare workers. We don't have that many, and they are very precious, but also our elderly. So just to plead for the rest of the world before they just move to vaccinate all the young population, that they think that's a very important population here that also need protection from these strong vaccines. Thank you.
Thank you, Prof. Dr. Richard, before we go back to Dr. Moeti.
Well, I think that there was a lot of question in the chat box around the acceptability and the rollout of the vaccine in the continent. So I would like just to reassure our audience that WHO is doing really all it can to increase the preparedness of the different countries to make sure that they are ready to introduce the vaccine when they become available. We are working quite very hard to make sure that a country can access the vaccine dose as soon as possible. Our risk communication and community engagement team, working with all the partners, really trying to make all the efforts to combat all the misinformation around vaccination, but to engage more actively the community for the acceptance of the vaccine. So we will continue to provide this support to the countries and make sure that the vaccine become available as soon as possible and support them for the effective rollout of this product. So thank you very much.
Thank you, Dr. Richard. And finally to you, Dr. Moeti.
Thanks, Mary. I mean, to finish, first, I'd really like to thank my co-panelists, Prof. Tulio and Dr. Sal. One, for the work that you're doing as scientists in the institutions that you are leading, but also very much for this strong engagement in continental solidarity in providing your facilities, your expertise to the other countries on the continent. I think it's an excellent example of what is needed, not only within the continent, but at the global level, as you both referred to in relation to access to vaccines, and as I said earlier, in referred to access to other items that are so vital in this global response. And then secondly, just to say, yes, we learn about new variants of the vaccine. Unfortunately, some of them look to be more, if you like, dangerous in terms of transmissibility. But at the end of the day, we need to go back to the fundamental actions that need to be taken by individuals in our families, in our homes, and by the public health systems of countries that are effective against these variants, even if they need much more emphasis than if the virus is much more transmissible. So again, as individuals, let us renew our commitment to what we have to do at home, at work, if we're actually going to work, to protect ourselves, to protect others, wearing our masks, keeping a distance, and hand washing and hygiene, and spreading the right information, both about the variants, the risk, and also about the vaccine. The vaccine is a tool that's going to make a huge difference all over the world. And so we are encouraging people to make yourself ready to receive it when it's your turn to receive it, and encourage others to do so. And then again, I'd like to add my own voice in terms of the global solidarity that's needed. And just remind that having a corner of the world not protected, the way the world's economies and peoples are connected, will have negative economic impact even in those countries that manage to vaccinate their entire populations, because as the professor said, we still have to learn about how long the immunity conferred by these vaccines lasts, and therefore if the susceptibility will return. These are all still open. So just to emphasize, we really are all in it together, and we have to work to support each other to overcome this global crisis. Thank you very much for having joined us, to all our journalist colleagues.
Thank you, Dr. Moeti, and I would like all participants to help me and join me to thank all our panelists, Dr. Matshidiso Moeti, the Regional Director for Africa here in Brazzaville, Dr. Richard Mihigo from the regional office in Brazzaville, Professor Tulio from South Africa, and Dr. Amadou Sow from Institute Pasteur, all the way from Dakar. Thank you very much. As we go, Dr. Richard is happy to stay and address some of the French media questions for some time, so you can hold on. Thank you. The press conference is over.
Thank you.
Thank you very much. Bye.
Bye, thanks.
Merci. Juste pour vous dire que pour les journalistes francophones, vous pouvez, il y a le docteur Richard Mihigo qui est là et qui peut répondre à quelques questions en français. Merci.
Oui, bonjour. Donc ici, c'est Khadija Diallo. Je suis à la communication au bureau régional. Je vais essayer de faciliter avec Dr. Richard Mihigo pour certaines questions qui ont été reçues en français. Je ne sais pas, est-ce que Dr. Richard, vous êtes connecté, Dr. Mihigo?
Oui, absolument, je suis toujours en ligne. Oui.
D'accord, merci. Donc, on a reçu plusieurs questions qui se ressemblent. Hein, donc, je vais essayer un peu de faire un récapitulatif. Mais la première question que je voulais relayer ici, elle a été posée par Mariama Mané de la RTS, Radio-Télévision sénégalaise. Donc, elle demande, est-ce que les personnes souffrant de maladies chroniques doivent se faire vacciner et doit-on vacciner une personne qui a déjà développé la maladie? Et enfin, est-ce qu'après cela, la personne vaccinée sera immunisée pour de bon? À vous, Dr. Mihigo.
OK, merci pour cette question. Il faut d'abord préciser que la vaccination a pour objectif ultime de protéger toute personne contre l'acquisition d'une maladie infectieuse. Et éventuellement, une fois cette personne vaccinée, ne pas, dans le cas échéant, faire de formes graves de cette pathologie. Alors, en ce qui concerne les personnes avec des maladies chroniques, nous avons malheureusement constaté que ces personnes sont des personnes hautement à risque lorsqu'elles contractent le virus de la COVID. Ces personnes sont extrêmement exposées à des risques de formes graves et éventuellement une mortalité élevée dans cette couche de la population. Donc, il est extrêmement important que ces personnes-là soient vaccinées pour éventuellement éviter de tomber dans cette situation. Alors, pour les personnes qui ont déjà fait la maladie, est-ce que c'est important de se faire vacciner? Absolument, parce que jusque-là, nous ne connaissons pas encore, et ça a été dit lors de la conférence qui vient juste de se terminer, jusqu'à quand et comment est-ce que la protection va durer. Et nous pensons que les recommandations actuelles restent de faire vacciner tout le monde, y compris ceux qui ont éventuellement fait la maladie et qui en sont sortis indemnes, parce que la vaccination va certainement jouer un rôle de booster de leur système immunitaire pour aller de l'avant.
D'accord. Merci, Dr. Mihigo. Nous avons reçu notre question de Pamela Kumba de Channel Africa. Elle voudrait savoir, est-ce qu'il y a déjà un vaccin pour le nouveau variant en Afrique du Sud? Et à ce jour, combien de pays africains ont commencé la vaccination? Et enfin, avons-nous déjà quelques résultats?
Bon, comme ça a été dit lors de la conférence qui vient de se terminer, les premières données que nous avons pour le moment, en tout cas pour ce qui concerne les données de certains vaccins comme celui de Pfizer ou de Moderna, viennent de montrer que leur vaccin reste quand même efficace contre les nouvelles variantes qui ont été détectées, et principalement la variante du virus britannique, mais également la variante sud-africaine. Alors, il est important de continuer à faire la surveillance de la circulation de ces différentes variantes et voir dans quelle mesure les différentes mutations pourraient influencer sur la validité ou l'efficacité des vaccins futurs. Donc, pour les autres candidats vaccins, nous attendons encore des informations sur la protection éventuelle de ces vaccins contre les variantes qui viennent d'être détectées. Donc, c'est quelque chose qui doit continuer à être surveillé de près. Mais il faudra souligner une chose, que la meilleure stratégie d'éviter que ces variantes ne deviennent dominantes, c'est que les gens puissent d'abord se faire protéger avant. Et lorsque nous protégeons les gens avant, soit par les mesures barrières dont nous avons, le docteur Moïti a insisté, mais également la combinaison de ces mesures barrières avec une vaccination, cela nous permettra de limiter la circulation du virus et éventuellement éviter la survenue des nouvelles variantes qui peuvent échapper à l'efficacité de ce vaccin-là. Alors, pour ce qui concerne les nombres de pays qui ont déjà introduit le vaccin, comme je l'ai souligné avant, nous avons les Seychelles qui ont commencé la vaccination depuis le 10 janvier avec le vaccin de Sinopharm. À la date d'aujourd'hui, presque 25 000 personnes ont été vaccinées dans ce pays-là. Il y a 2 jours, l'île Maurice a également commencé la vaccination en utilisant le vaccin de AstraZeneca. Et aux environs de 450 personnes ont déjà été vaccinées depuis les 2 derniers jours. Et l'objectif de la vaccination dans cette île est de vacciner jusqu'à 60% de la population. D'autres pays au niveau de l'Afrique ont commencé également à planifier la vaccination. J'ai parlé du Maroc, qui a reçu également 1,5 million de doses de AstraZeneca la semaine passée et qui commence la vaccination, je pense, aujourd'hui ou demain. L'Afrique du Sud a également annoncé l'arrivée de presque 1,5 million de doses de vaccins de AstraZeneca et l'Afrique du Sud va également bientôt commencer la vaccination. Et nous travaillons étroitement, l'OMS, avec le gouvernement sud-africain pour appuyer les préparatifs pour l'introduction de ce vaccin. Et nous espérons que la plupart des pays africains vont commencer à recevoir les vaccins à travers l'initiative COVAX dans les semaines à venir et en espérant que vers le mois de fin mars ou plus tard, les toutes premières doses devront commencer à être distribuées à l'ensemble des pays dans la région de manière proportionnelle.
D'accord. Il y a une question qui est revenue plusieurs fois. Il y a posée tout d'abord par Eugénie de Radio Pyramide au Togo et également par Katobio Msiri de RDC. Donc, c'est par rapport au fait qu'il y aurait des informations sur les réseaux sociaux selon lesquelles le Coca-Cola rendrait le test rapide du Covid positif. Donc, il voudrait qu'on commente par rapport à cela, sur le Coca-Cola qui rendrait le test positif Covid.
Bon, écoutez, nous avons vu ces derniers temps pas mal d'informations qui circulent sur les réseaux sociaux. Et effectivement, on a pu voir cette vidéo qui est devenue virale sur les réseaux sociaux. Il n'y a aucune raison de penser que le Coca-Cola le rendrait parce qu'il n'y a pas de virus dedans. Donc, il faudra que nous puissions effectivement nous méfier beaucoup de ce genre d'informations. Nous avons au niveau de l'OMS constitué un groupe qui s'occupe de infodemic, je ne sais pas comment traduire ça en français, pour essayer effectivement de rechercher la plupart de ces informations qui circulent sur le web, de travailler à ce que nous puissions donner la bonne information en ce qui concerne effectivement les faits qui sont avérés par la science et dissocier cela des nouvelles qui circulent sur les réseaux sociaux sans aucun fondement en ce qui concerne des évidences scientifiques. Donc, c'est tout ce que je peux dire sur ce sujet.
D'accord, merci docteur. Et également une question qui revient de Chris Octave et également de Christiane Ekambo. Christiane Ekambo, elle est de RDC, elle voudrait savoir quelles sont les mesures qui vont être prises pour convaincre les Africains et puis venir à bout des résistances, surtout quand on se rappelle la vidéo qui avait été publiée par les chercheurs de l'INSERM sur la chaîne française LCI par rapport à la vaccination en Afrique. Et une question similaire un peu, de Eugénie du Togo qui dit que, étant donné que la COVID-19 fait moins de victimes en Afrique, est-ce qu'on a réellement besoin de ce vaccin? Et beaucoup craignent que le vaccin ne tue plus que le COVID-19. Et donc, comment on va venir à bout de ces résistances et pourquoi réellement l'Afrique, étant donné qu'il y a moins de décès en Afrique, pourquoi a-t-on réellement besoin de ce vaccin?
OK. Donc, en ce qui concerne la première question et notamment la perception de l'acceptance du vaccin ou pas, et la vidéo, effectivement, de chercheurs de l'INSERM qui date de quelques mois, je crois que l'année passée, au mois d'avril-mai. Je pense que je voudrais d'abord insister sur le fait qu'en son temps, l'OMS avait fortement condamné ces propos que nous avons jugés extrêmement préjudiciables sur la vaccination, mais également qui avait une connotation carrément raciste. Et nous avons, à tous les niveaux, extrêmement condamné cette sortie. Et d'ailleurs, les mêmes scientifiques s'étaient excusés par rapport à cela. Alors, en ce qui concerne l'acceptation de la vaccination, il faudra peut-être des fois dissocier ce que nous regardons sur les réseaux sociaux et la réalité. En partenariat avec nos collègues de Africa CDC, nous avons conduit une étude assez représentative dans 15 pays de la région africaine pour essayer d'analyser la perception et surtout la possibilité des différentes populations au niveau de la région africaine pour accepter le vaccin. Et je peux vous rassurer que les résultats de cette étude sont extrêmement positifs. Dans certains pays, nous avons jusqu'à 95% des gens qui ont dit qu'ils étaient prêts à se faire vacciner. Et dans d'autres, c'est vrai que nous avions quand même une proportion assez importante, entre 15 à 20%, voire 25% des gens qui doutaient un peu des bienfaits de la vaccination. Mais je crois que ce qui est important ici de souligner, c'est que de manière générale, les populations africaines n'ont aucun problème avec la vaccination. Dans la vaccination de routine de tous les jours, nous assistons à une situation où les parents amènent leurs enfants à la vaccination sans aucun problème. Donc, nous n'avons pas spécifiquement de problème de vaccination en Afrique. Alors, la situation actuelle, c'est vrai, avec la COVID-19, et pour répondre à la question du deuxième journaliste, pour dire est-ce que la COVID ne tue pas moins en Afrique, est-ce que c'est important? Je pense que la réalité est que nous avons presque 3,6 millions de cas qui ont été répertoriés en Afrique et presque 90, nous atteignons presque les 90 000 décès. Et comme nous savons, des fois, les systèmes de rapportage dans certains pays posent des problèmes sur la vraie ampleur de la maladie, je crois qu'il est extrêmement important que les journalistes, vous nous aidiez à sensibiliser l'opinion sur la dangerosité de cette maladie, sur l'importance de se faire vacciner, parce que ce n'est que ça qui pourra mettre réellement un frein à cette pandémie.
Merci, docteur. Juste pour clôturer, parce qu'on est pris par le temps, je voudrais juste rappeler à tous les confrères journalistes que les questions ont été combinées. Donc, beaucoup ont reçu déjà réponse. Donc, pour conclure, juste deux dernières questions. Une de ces questions, elle vient de Anderson Akoué du Togo, qui commente en disant « En refusant de faire partie de l'alliance COVAX tout en privilégiant le Covid organique, est-ce que la position de Madagascar ne risque pas d'influencer d'autres pays du continent qui ont des remèdes locaux? Et est-ce qu'il y aurait des sanctions pour les pays réfractaires à la vaccination ?» Et la toute dernière question venant de Mustapha Azouga du Maroc, est-ce qu'il y a des initiatives pour délocaliser la production des vaccins développés par les laboratoires dans le continent? Merci. À vous, Dr Migo.
OK. Vraiment des questions assez intéressantes. Pour la première, en ce qui concerne Madagascar et éventuellement la COVID organique, comme vous le savez, Madagascar a été fortement affecté par la pandémie et nous avons tous vu les limitations cette fameuse, je dirais, potion qui est la Covid organique. Après l'été où nous avons vu au mois de juin-juillet une plus ou moins stabilisation et retombée des cas partout en Afrique, nous avons vu, comme partout ailleurs, une remontée spectaculaire des cas à Madagascar qui a même poussé les autorités à remettre en place certaines mesures de restriction de mouvement des populations comme nous l'avons vu dans le passé. En notre connaissance, Madagascar n'est pas réfractaire à la vaccination. Ils font bel et bien partie de l'initiative COVAX et dans la planification que nous avons au niveau de l'OMS pour la distribution de vaccins, Madagascar est bel et bien parmi les pays qui vont recevoir les vaccins à travers l'initiative COVAX. Maintenant, est-ce qu'il existe des sanctions pour les pays réfractaires? La position de l'OMS a toujours été de dire que la vaccination ne doit pas être nécessairement imposée aux pays ou aux individus, mais notre réellement position a été de faire comprendre aux communautés, aux populations, aux États, les bienfaits de la vaccination, l'importance de se faire vacciner. La décision d'imposer la vaccination de manière obligatoire ou pas, finalement, revient aux pays eux-mêmes. Ce n'est pas à l'OMS de prendre ce genre de décision, ni à toute une autre organisation. Et jusque-là, la plupart des pays ont été, de manière largement concertée, prêts à lancer les campagnes de vaccination. Donc, c'est quelque chose d'extrêmement important à souligner. Et votre dernier point, c'était sur l'initiative. Vous pouvez un peu rappeler, Khadija?
C'était sur le fait qu'on pourrait peut-être délocaliser la production.
Ah oui, voilà. Alors, pour la délocalisation, effectivement, ça, c'est quelque chose d'assez important. Je ne l'ai pas peut-être souligné dans la partie anglophone de l'interview. Il y a le vaccin de Johnson & Johnson qui est actuellement en dernière phase d'essai clinique en Afrique du Sud, va être produit en Afrique du Sud. Donc, l'Afrique du Sud vient de signer avec la firme Johnson & Johnson la possibilité, non pas la possibilité, vient de signer un partenariat pour la production du vaccin de Johnson & Johnson au niveau de l'usine de Aspen Pharmaceuticals qui se trouve au niveau de l'Afrique du Sud. Donc, nous commençons déjà à voir à cette délocalisation. Il y a également des discussions assez avancées au niveau du Maroc pour qu'une partie de vaccins de Sinopharm puisse également être produit au niveau local au Maroc. Mais je pense que de manière future, il est clair que la stratégie est de faire en sorte à ce que la capacité de production des vaccins au niveau africain soit augmentée pour que dans les pandémies futures, et personne ne souhaite ça, l'Afrique ait la capacité effectivement de réagir assez rapidement dans la production des vaccins en utilisant des solutions locales au niveau du continent.
Voilà, merci Dr Mhigo, c'était tout et merci à tous les journalistes qui sont restés et à vous François.
Ok, merci et à bientôt.
Merci docteur, au revoir.
Au revoir.